invasive extracorporeal circulation in enhanced recovery after surgery programs. So enhanced recovery after surgery programs have become quite widespreadly talked about since the mid-1990s, after they were introduced by the professor of surgery at Copenhagen University, largely to address outcomes after colorectal surgery. They are bundles of care, multi-professional and multidisciplinary teamwork, evidence-based bundles with continuous audit and feedback in the process. But importantly, the whole team has to be ready to make a change of their normal practices. You can see from this graph that the whole surgical community across widespread surgical disciplines has started to talk a lot about ERAS pathways, but it's only in the last couple of years that ERAS in cardiac surgery has started to be talked about. The outcomes claim to have reduced complication rates and shorter lengths of stay, but the Cochrane collaboration is a little bit more guarded, considering the evidence to be often based on quite poor evidence, that there are high risks of bias, but most importantly, there are few long-term patient-recorded outcome measures in the trials. If you want a system to change, the first thing is to be dissatisfied with the current state of play. Cardiac surgeons have a reason not to be dissatisfied with the current state of play. Mortality continues to fall year on year, and that's at the same time that our patients are becoming more complex, as evidenced here with the SCTS database, with the Euroscore steadily rising year on year. But if we're going to take up the Cochrane challenge, we need to look at something much more important to patients, which is their quality of life extending after cardiac surgery, about which we know not very much, but this study suggests that after cardiac surgery, patients have an improved quality of life, even extending up to 10 years after cardiac surgery compared to their baseline. We also know that a third of our patients have complications, and some have serious complications. And if you stay in intensive care even for 3 days or longer, your quality of life extending out to a year is significantly worse than those patients who stay in intensive care for less than 3 days. And the team at Duke have looked at the early quality of recovery after surgery and have shown that if you have a non-cardiac complication or a combined non-cardiac and cardiac complication, your early quality of recovery is significantly worse than if you either have a cardiac complication or no complication at all. And Paul Miles has made a clear association between that early quality of recovery, even measured as early as 3 days, with your quality of life at 3 months. And there's at least a moderate association with quality of life extending out to 3 years. So if we in fact shouldn't be satisfied with the current state of play, what is the vision for how things might change? This paper was published in JAMA in May. It's one of the most downloaded papers in their history, from Daniel Engelman and a large group of collaborators. And in that, they describe a 22-bundle strategy for enhanced recovery after cardiac surgery, extending from the preoperative preparation right through to discharge from hospital. The team at Wake Med incorporated that ERAS in cardiac surgery pathway and studied it for 9 months and compared it with 9 months before ERAS in cardiac surgery was introduced. Their results show that the postoperative length of stay was reduced by a day, that patients stayed in intensive care for 15 hours less, and the main complication that was reduced was return of normal GI function, but notably the post-op ventilation, re-intubation, and readmission to CICU were not different. And depending on your point of view, you may be somewhat underwhelmed by that change, But you will also perhaps be aware, if you've seen this paper, that there are no bundles which incorporate any advice on how to manage CPB. And that's important because we've known for a decade that the duration of CPB, that is the insult of bypass, is an independent risk factor for postoperative death and almost any other complication that occurs after cardiac surgery. But you may also sit there and say that we can't do very much about the need for CPB, and in addition, we can't do very much about the duration of bypass, as evidenced in the same paper. But of course, if we can't do anything about the need for bypass or the duration, what we can do something about is the type of bypass that is used for our patients. Now, the authors did make reference to this in that paper in JAMA. In a conclusion, they indicated that they would anticipate preoperative anemia management, some anaesthetic considerations, and in relation to bypass, goal-directed perfusion to be incorporated into ERAS pathways in the future. And one of the authors who came from Wake Med further expanded on that and has said that the size and length of tubing, blood-based cardioplegia, and monitoring not only of the patient, but also of the circuit is likely to be incorporated, but currently the evidence wasn't strong enough for incorporation in those pathways. That's a real likelihood because we know that of the two major complications that alter quality of recovery after cardiac surgery, then at least two meta-analyses shown here have shown a significant reduction in the incidence of acute kidney injury and the incidence of atrial fibrillation by using miniaturized extracorporeal circulation compared to a conventional circuit. So if we're dissatisfied with the current state of play, we accept that there is now a line in the sand, a clear vision of how we might go. What are the first steps so that we can overcome any resistance to change? And that first step is surely the completion and publication of the COMEX trial. Thank you very much.
Mark, before we go on, we have a commentator who is Christophe Baufreton with us and unfortunately has to go in 10 minutes. So can we give him time to comment so far?
Professor, would you like to ask any questions of the speakers so far?
Good morning, everybody. I'd like to congratulate all the participants to that meeting and all the comments they've done. And I totally agree with what has been said this morning, although it's difficult for me to get all information due to the connection, which is a little bit unstable. There is something I would like to emphasize, and probably has not been discussed a lot, is the level of anticoagulation it's going to be used for cardiac surgery. I really think we have to rethink our level of heparinization, and that if we want to reduce the anticoagulation, that would be a good opportunity to manage in a better way all the patients, especially because our patients are currently more and more referred to us with the addition of aspirin, of course, but also other antiplatelet agents like clopidogrel or ticagrelor, and we don't need to give so much important heparin level like an ACT above 480 seconds. And it's very interesting if you go back to the whole literature, the one that has been the basis of evidence-based medicine, the paper of Bull in 1975, you are going to read in that paper finally that if we go too far in heparinization, then we're going to have some trouble and we give probably too much heparin. And this is the reason why I would truly advocate for a reduction of anticoagulation, in addition in those type of high-risk patients for bleeding. And by the way, we can reduce CFE. Of course, if you read the very last recommendation in guidelines, this is not precise so exactly, but I think this is the direction we have to work for the future. This is my main comment I would like to give you.
Thank you very much. We're going to move on, but thank you very much for that comment. That adds nicely to what's already been said. So the last presenter for this